Welcome all of you to this live program on orthopedic principles. Today, our guest of honor is Dr. Michell Ruiz from Mexico City, Mexico. Dr. Ruiz was appointed as attending physician at the National Institute of Rehabilitation in Mexico after finishing a sports medicine fellowship at the Plano Orthopedic and Sports Medicine Center in the US, a shoulder and elbow fellowship at the same institute, and Arthroscopy Association of North America traveling fellowship. He is a founding partner and attending physician at the Traumatology Deportiva de Mexico, where he's also the co-director of the Sports Medicine and Shoulder and Elbow Fellowship. He serves as an associate editor of the Acta Orthopedica Mexicana and is an editorial member and reviewer for several shoulder surgery journals. He has been the past president of the Mexican Society of Shoulder and Elbow Surgery. So today is my great honor to introduce you to Dr. Michell Ruiz from Mexico. Over to you, Michell.
I'm doing great. Thank you very much. The honor is mine of being once again at your channel. Thank you very much. So shall we start?
Yeah.
Thank you very much. So I was invited to talk to you about the use of the intramedullary nails for 2, 3, and 4-part proximal humerus fractures. It has been a topic that I've been familiar with probably in the last 3 years. I have to tell you that I was a plate guy, although most people recognize me as a replacement guy for these type of fractures. But since 3 years ago, I discovered this fabulous device for humerus for proximal humerus fractures, and I just came in love with it, and I'm going to try to convince you. So I have a couple of disclaimers. This is not what I do at my department just by myself. I have to tell you that this is the preferred technique at our department at the Instituto Nacional de Rehabilitación, the National Institute of Rehabilitation in Mexico. It is part of the National Institutes of Health at my home country. And we are a national referral center at the orthopedic trauma department. And I have to tell you that this technique that I'm going to show you, or techniques, are equally mastered by all the surgeons that participate at our department. At the present time, Dr. Eleazar Garcia Martinez is a division chief. Dr. Jorge Ponce de Leon is the head of the department. And I have my fellows attending physicians that are Dr. Gerardo Gutierrez, Dr. Leonardo Moreno, Dr. Bernardo Petet, Dr. Mariel Hernandez, and Dr. Ernesto Torres, that I can tell you that this talk could be given by any of them without any problem. And I have to recognize these two guys that appear in the picture. The doctor on my right side is Dr. Eric Hassan. He was a former division chief of our at our institution for many years. He's now retired from the Instituto, and he was familiar with the first generation nails back in probably mid-90s. He had a fellowship training in Houston, and he was very familiar with a Polaris nail that was the first IM nail for proximal humerus fractures that has some characteristics. And then Dr. Ernesto Pineda, that appears to my left in the picture, was the head of the department at our institution for many years. He's right now retired, and he was the one that pushed really hard with the use of these third generation IM nails that I'm going to talk about. So why use an IM nail for a proximal humerus fracture? Well, first, from my perspective, it can be done in all fracture patterns. If you're a plate guy, like most of the orthopedic surgeons in the world are, you can do almost the same. You can use this device in the same fracture patterns that you can use a plate. But a big advantage is that in 2-part fractures, especially at the level of the surgical neck, it can be done percutaneously. and also in 3 and 4 port fractures, it can be done with minimal soft tissue dissection. And one huge advantage from my perspective is that in osteoporotic bone, that is probably the majority of the cases, the use of this device can spare you the use of a structural graft that on the long term, it can bring some other difficulties, especially if you have to convert to another device, especially to an arthroplasty. It can spare you the use of iliac crest graft, the use of a fibula that has gained a lot of traction in the last years. But from my perspective, it can bring more problems than advantages, especially if you have to convert it on the long term. Now, the IM nails have some advantages also from the biomechanical and biological point of view in comparison to plates. But first, it has the nails have an improved rotational stability in comparison to plates. Due to the fact that you need to do less soft tissue dissection, it can preserve a better periosteal blood supply. Also, if you need less soft tissue dissection, in most of the cases, there is less pain, less post-op pain. And that is a huge advantage for all the patients. And if you mix all these advantages, it can also bring you another one that is very important, and it is the reduced risk of a vascular necrosis. But of course, as with any other fracture and with any other device, you have to do a very careful patient selection. So there are clearly some cases in which the patient will benefit more with the use of a conservative treatment, just plain old immobilization. Or on the other side of the spectrum, also we can find patients that will benefit more with the use of an arthroplasty. There will be an anatomic or a reverse, especially in cases in which you will have a chronic dislocation of the head, that you will have a head split, or in cases in which you will have a comminution of the greater tuberosity. Probably in those cases, the IM nail will not be the best option, but still, fortunately, those particular cases are not the most frequent ones. In osteoporotic bone, as it is in the majority of the cases, it has clear advantages because you don't have to use a structural bone and a structural graft just to keep the fracture reduced, because the nail can serve as a core inside the bone, and around it you can reconstruct the fracture. It also has clear advantages in patients with multiple comorbidities, and of course in polytrauma patients. So you have to understand the fracture pattern as in any other fracture. And if you understand how the displacement of these 4 fragments that are the ones in which these fractures are divided, it is going to be a lot easier to do the reduction maneuvers and also to place this device or any other device. So the fragment number 1 is the head, the humeral head at the level of the anatomical neck. Fragment number 2 is the lesser tuberosity that is after a fracture is not usually very immediately displaced. In most cases, or in many cases, it can remain attached to the head. Fragment number 3 is the greater tuberosity that usually displaces posterior and medially due to the rotator cuff vector force due to the supraspinatus pull, infraspinatus, and of course the teres minor. And number 4 is the humeral shaft that with its attachments of the pec major and the latissimus dorsi is going to have some inclination and also displacement to the medial side of the patient. And this is something that concerns me a lot, especially with the use of plates. You have to understand which is the blood supply to the proximal humerus from the anterior, as you can see here, and also from the posterior side of the humerus. In many cases, you have to place a plate on top of these very important vascular structures, and that may compromise the vascular flow to the head, and that may even compromise a little bit more the possibility of having a vascular necrosis of the proximal head, and not only having the risk factor of the fracture itself, but also the placement of a device. I think this is not the time to explain how the nails have evolved since the mid-90s, but I have to tell you that right now we are in this era that we have these so-called third generation IM nails, and they have a lot of advantages with respect to the previous two generations. These third generation IM nails are shorter than the previous ones. They are straight in comparison to the second generation, in which they are curved, and they are smaller in diameter in comparison to the previous generations. Due to these characteristics, the entry point is through the supraspinatus muscle, or in some cases, you can do it through the rotator interval. If you do it through the rotator interval with an intact supraspinatus, from my perspective, you are going to be a little bit anterior from the optimal entry side point. So if you go with a regular entry point, as with any other third generation IM nail, I think you're going to hit the right spot 100% of the times. And a huge advantage is that although you're going to penetrate the head and the articular cartilage, it is going to be a part of the head that is not going to be in contact with the glenoid. So there is not going to be a complication because of the placement. Another characteristic that is very important with these third generation IM nails is that they have plastic bushings, or depending on the brand, they have threaded holes for lock and screw. So one of the disadvantages of previous generations that in many cases the locking screws, proximal locking screws, will disengage from the device, and that will pose a lot of complications and risks because of fracture displacement. But with these newer devices, that usually does not occur if you follow all the instructions. Depending on the design of these third generation IM nails, some designs, some nails have the possibility of having screw-in-screw options. With this, I'm trying to tell you that you can have a locking screw, and through that locking screw, you can place another locking screw that you can place posterior or anterior, depending on the fracture pattern, and that gives you a better tuberosity fixation. And also, some other designs will allow you to place some calcar screws that provide much more support for various displacement, as you're going to see in some figures a little bit later on. These new nails have also a blunt tip, and this blunt tip will prevent the articular penetration that has been reported as a complication with previous generations. And the direction of the locking screws with these newer nails is have a more divergent direction, and that can give you a lot of better support in comparison with previous devices. So on the top part of the figures, on your left side, is demonstrating which will be the entry point for second generation nails that will be very lateral, almost in the rotator cuff footprint. And as you can see, the fixation of the head will not be very good, and also you will have to violate the supraspinatus tendon. That is a complication of these second generation nails. With third generation nails, as you can see on your right, the entry point is much more immediate, and it will be almost like if you will be placing any stem for an arthroplasty, for a shoulder arthroplasty. And the huge advantage is that with these new locking screws and all these divergent direction of fixation, you have much better fixation of all the fracture fragments. And on the same time, you're not going to have a complication due to the entry point, because as you can see it here, the entry point is so high that even if you hyperabduct, you will never have a contact of the articular cartilage against the glenoid. And so this is something very important, how you will surgically approach an IM nail. And I will tell you that the decision depends on the number of fracture parts. So if you have a two-part fracture, and in this case, we are talking about a two-part fracture at the surgical neck level. Of course, if you're going to have a two-part fracture at the lesser tuberosity or greater tuberosity, an IM nail is not going to be the best option. Probably just regular screws will be more than enough. But if you're going to have a two-part fracture at the surgical neck, then you can do a percutaneous approach without any problem. For 3- and 4-part fractures, I usually do a superlateral approach that I'm going to demonstrate you a little bit later. And there are some other cases. If you have a fracture with an anterior dislocation of the humeral head, you can still use a superlateral approach. Although for doing the head reduction, it requires a little bit more experience with this type of approach. But on the other hand, you can do a regular deltopectoral approach, which is relatively straightforward, and most of the surgeons are very familiar with this kind of approaches. And you can do the head reduction through this approach, and then just place the nail as you will regularly do. And in cases of fractures and posterior dislocation of the humeral head, you can still do the humeral head reduction without any problem from a superlateral approach. In terms of patient positioning, I would say that it varies very little depending on the fracture pattern, but I could tell you that if you're going to do a percutaneous approach in cases of two-part fractures, I will use a very lazy semi-fowler position that in some cases you could place the patient even completely horizontal. And for all the surgical team, that makes things a little bit easier if you're working with residents and fellows. It's also very easy for them to help you all throughout the case. If you're going to do a superlateral or deltopectoral approach in cases of fracture dislocations and 3 and 4 part fractures, I think the best position will be a beach chair position. And of course, you need the C-arm positioning. This will be my regular configuration. I will place the C-arm at the level of the head of the patient in this position, and I will only rotate the shoulder just to have an AP and an axial view. It's very easy. You don't have to move the arm. You don't have to rotate the arm a lot. I'm going to place the screens at the foot of the patient just to keep an eye all throughout the case. And if the C-arm gets in your way while during your case, you can only move it, slide the C-arm to the opposite side of the patient, work, and just slide it back again. And then you will be just in the right spot to continue with your case and with the fluoroscopic control. So now we're going to start with approaches because this is where all the things get interesting. In two-part fractures, especially at the level of the head, as we told you previously, we can have basically two variants. These are various impacted fractures in which the head is usually posterior medially displaced. And in these cases, you can place the nail through a Nevius portal, just as you would use a Nevius portal for rotator cuff repair in arthroscopic surgery. It's just the same portal. As you can see in the figure at the bottom, the letter D will demonstrate where is the Nevius portal, although I will do it a little bit more medial and more centered in order to have a better direction to pin my head just first. And in cases of valgus impacted two-part fractures, usually the displacement is anterolateral. So in this case, I will use anterior entry points. And for these anterior entry points, you can go just anterior to the acromion and go as lateral as going a little bit more lateral to the lateral border of the acromion, or you can go medial, just as medial as the AC joint will be located, and just through the anterior border of the acromion and even the anterior border of the clavicle. This is a very interesting study and report by Dr. Pascal Boileau and his team, in which he describes which will be the best entry points for these type of fractures. But in real life, it's very easy because a lot of techniques are very well described in paper, but then when you want to translate it to the OR, they are not as easy as they would say. But in this case, doing it through a Nevius portal is very easy. As you can see here, the patient is in a very lazy semi-Fowler position. I will place first my guide pin through the Nevius portal. I just have to make probably a 2.5 centimeter incision, horizontal. And once I have my desired placement of this guide pin, I will just trephinate and then place the IM nail through the portal. In general, even if we have very obese patients, the locking guide will be in a very adequate length to do the rest of the case without any problem. If you want to follow this from the fluoroscopic view, as you can see in the middle picture at the top, the only trick here is to place your guide pin a little bit more oblique than you will do with anterior entry points. So once you see that your guide pin is just in the dead center of the head, you will just have to trephinate, then do a manual traction and control of the diaphysis, and just slide the nail through the diaphysis and just place your locking proximal screws and then lock distally, and that's the end of the case. And everything can be done percutaneously. In cases in which you have valgus impacted fractures, then, as I told you before, you can use more anterior entry points. In most cases, I will do my entry point at the level of the acromioclavicular, anterior to the AC joint. As you can see the staples here, this will be my regular entry point, just anterior to the AC joint. And I will use that entry point for valgus impacted two-part fractures, and also for all my diaphyseal humerus fractures in which I'm going to place an IM nail. That will be almost my same entry point. And as you can see from all these surgical staples, this is a very good percutaneous approach. But what happens when you have 3 and/or 4-part fractures, and you need to do a reduction just to have an anatomical reduction of the fracture? So this approach was inspired by Pascal Boileau's work, and we have been able to reproduce it quite well. So first, I will do a superlateral approach, but at the level of the skin, I will do a savory skin incision. This is because it is more cosmetically beneficial. So I will start at the posterolateral corner of the chromium and go directly to my coracoid. And although it is you could say a big incision, it's approximately 8 to 10 centimeters in length. It is going to be very, very cosmetically pleasant for any patient because the scarring is minimal. But once you do this saber incision, I am going to develop two skin flaps. So I'm going to do a very thorough dissection of the subcutaneous tissue on the medial side of the incision, and then refer it with two sutures. I'm going to do a very thorough dissection of the lateral flap of the skin with subcutaneous tissue, and also place two traction sutures, as you can see here. And then we're going to proceed with a superlateral approach. My superlateral approach is going to start just medial to the AC joint. And then I'm going to disinsert the deltoid. Although Dr. Boileau takes a little fleck of bone just to do a repair and have bone-to-bone healing, I just do a regular deltoid disinsertion, and I have not had any problem. Once you get there, you're going to use two Richardson retractors, and then you can have the identification of the greater tuberosity and place some traction sutures. Here you can clearly see the supraspinatus, the infraspinatus, and the teres minor. 2 or 3 traction sutures will be more than enough. And then I'm going to place a traction suture on the lesser tuberosity at the level of the subscapularis. And in cases I have an anterior humeral dislocation, I can do that reduction just behind the subscap, because that way I can find very easily my head, or do the reduction if I have a posterior head displacement with a posterior dislocation. In this case, this was an approach for an arthroplasty. So in this case, we're not going to see the head, but as you can see here, you have a very clear view of what inside the joint would look like. But in cases you have the head and you're going to do an IM nail, you're going to do just this same approach. You're going to do a saber skin incision. You're going to do a superlateral approach with a disinsertion of the anterior deltoid at the level of the junction between anterior and medial deltoid. You're going to place your traction sutures for each tuberosity, and then you're going to identify the head. Once you identify the humeral head, like in this case, this is the same case in which there was an anterior humeral dislocation. I just did the humeral reduction, the humeral head reduction, just posterior to the subscap. I just with a bone hook, I just tractioned my humeral head, and once I have my humeral head, I just direct it and face it directly to the glenoid. Once I do this, then I'm going to place my guide pin. And as you can see here, it's quite medial, just as you will place any stem for a shoulder replacement. And then once you place your nail, a straight nail, you're going to reconstruct the tuberosities around the humeral head. And once you have very good control, especially of the greater tuberosity, because it has been lately reported that it's probably the most important structure after a 3 and 4 port fracture, because that is going to keep the blood supply to the head and also going to preserve the shoulder function after a fracture. And this will be the case. As I told you before, there are some designs that have the option of placing a calcar screw that will provide a little bit more support, but I don't have any conflict of interest with the device, but you have to know that in the market you can find this type of devices, and as you can see, the final result is very good. But also you can do a nail through a dentopectoral approach, as I told you before, especially in cases in which you have an anterior dislocation of the head. This was a patient that had a chronic dislocation of the head. She attended the ER, and the physician that was in charge thought that it was not that chronic, and probably he could do a close reduction of the shoulder, but it turned out that it was very chronic, and there is a dislocation, a fracture at the mid diaphysis. So in this case, I'm still going to use a IM nail, but through a dentopectoral approach, so I can do the humeral head reduction. In this case, I will do a dentopectoral approach, as you can see on the figure of the left. Then I will identify the biceps and do a tenotomy with a tenodesis. Afterwards, I will do a subscapularis tenotomy with its referral, and then I will do a very thorough dissection of the posterior capsule that in these cases scars against the glenoid, and then I will do the close reduction. After doing that, then I will place the nail just with the same entry point that as I have told you before. And the goal of using an IM nail is to have a fixation of the humeral head, of the greater tuberosity and the lesser tuberosity. Probably if you read Dr. Boileau's papers, he's more on the only greater tuberosity fixation. I do not have any experience with his nail. That is a different kind of nail. But at this point, use just regular nails in which you have locking screws that are directed to the head, and we have not had any problem at all. At least you will have to have these 4 points of fixation, at least 2 to the greater tuberosity and the head, 1 for the lesser tuberosity, and 1 to the surgical neck, just to keep this rotational stability of the fracture. And as with any other implant, you need orthogonal views just to keep control of your reduction and your implant position, final positioning and locking, just to prevent, because as with plates, you could inadvertently place a very long screw to the head and penetrate, and then have a very ugly complication. We don't want that, so it's important to have all through the case these orthogonal views, so you can keep track of what you're doing. And once you are familiar and feel comfortable with your implant and with your technique, you can even do the placement in 3 and 4 fractures almost percutaneously. As you can see here, this is a varus impacted fracture. So we know that the displacement of the head is going to be posterior medial. We're placing our guide pin through the Nevius or portal, and then just play with the diaphysis with manual traction. And once we have our desired entry point and we have placed our trufine, then we will just align all the fragments, place our nail, then do a reduction with a Kelly clamp or any other device that you can place percutaneously, and then lock the rest of the nail without any problem. I'm not saying that this is the ordinary case, nor the ordinary surgeon. I think you have to have an important learning curve just to be able to do this. And but once you get familiar with a technique that takes probably 20 to 25 cases, you will feel quite comfortable in doing these type of techniques. But what does the literature says about the clinical results comparing IM nails against plates? This is a meta-analysis that was published some years ago, and they included studies from 1998 to 2006. So they included also, and I have to say this, first and second generation IM nails, not a lot of third generation nails, and still there were no significant differences in the clinical results comparing nails against plates in terms of constant Merle scores, nor in post-op complications. But with the huge advantages of using a nail in terms of being less invasive, you need a less incision length. You have less perioperative bleeding. You need less over time, and if you gather all these factors, then you have a less time to heal. And in terms of complications, what does the literature says? So in general, you can see that IM nails have less complications than plates. Plates, as we all know, unfortunately, have a lot of complications, and it's reported that almost 1/4 of all cases will end up in a complication that needs some kind of revision. Especially in various displaced fractures, the plates are going to perform a little bit worse than nails. Probably in the valgus impacted fractures, it's not going to make a huge of a difference, but in varus impacted with this posterior medial head displacement, I think that is where you're going to find a little bit more of an advantage using an IM nail in comparison with a plate. But of course, not everything is great. We have already published our initial experience starting from 2013 to 2018. This report was done by Dr. Edwin Valencia, that is one of the rising shoulder surgeons here in Mexico. It was published at the Acta Ortopédica Mexicana back in 2020, 3 years ago. And in that report, we included 84 cases, and we had a varus displacement in 11% of the cases at the 1-year follow-up. All these cases were done in various impacted fractures. So even if you place a nail, you're still going to have some displacement in the follow-up. But in the last 3 years, we haven't seen this type of displacement. So most probably these complications, quote unquote, will be due to our stage of learning curve. At this point, in these 84 cases, we have 30% of AVN, especially in the 4 port fractures. We included some fracture dislocations too, and of course, in the cases of fracture dislocations, many patients developed AVN. But even though a lot of patients, as you can see here, 30% of the cases developed some kind of AVN, the function was really, really good in 90% of the cases, because only 5 patients required revision arthroplasty. The rest, although radiographically showed some type of or some degree of AVN, they needed no other procedure. And finally, I want to state very clearly that I or our department are not IM evangelists, but we are eager to collaborate if you want to take a step into this technique. We are open to offer support and assistance to any surgeon or group that is willing to make a shift from their current practice. You have to be aware, because we are, that it requires a new learning curve, especially if you are very familiar with plates. But I have to be very clear. Our only interest is the patient's best interest. We're not trying to state here that we are able to do the IM nail very good. No, we are doing it because it offers a clear advantage from our perspective in comparison to plates, and all of this is in the patient's best interest, as I told before. Thank you very much.
Thank you, Michelle, for this very enlightening presentation. Michelle, you can stop sharing actually.
Yeah. Ready.
Thank you, Michelle, for this enlightening presentation. A lot of interest in nailing for proximal humerus fractures ever since you've made a post in LinkedIn.
Yes. Yes, that post on LinkedIn just attracted a lot of attention. And I'm happy that it attracted a lot of good attention. It was not of people trying to criticize, just people trying to be aware of this technique as another option to treat these kind of fractures.
Michelle, a few questions. Michelle, in the post-op rehab part, do you think immobilization in internal rotation is going to be of concern because of the pull of the great tuberosity?
I think so. But I think that will pose a greater risk in case of plate, in plate use. If you're going to use a nail, although we try to return to the patient's activities as soon as possible, we still do we still advise for some kind of internal rotation with a sling, and we haven't seen any displacement of the greater tuberosity due to the positioning.
And Michelle, you use a incision like this, right? The saber approach or the strap incision that you mentioned. Right. And yes, a lot of surgeons are, I mean, in addition to the standard deltopectoral incision, a lot of surgeons use the lateral deltoid split as well, right? So do you recommend the deltoid split while using a nail? Because I've seen a lot of surgeons, they prefer using the lateral deltoid split. So is it technically more difficult with that? What do you think?
You have to be aware that if you're going to use a nail, you have to approach from the top. So if you only do a deltoid split, I think it's going to be very difficult to position the device in just the optimal position. So in the first cases, my residents and fellows just get a little bit scared when I begin disinserting the deltoid, like, what are you doing? But if you do a very good reinsertion of the deltoid, you're not going to have any consequence of doing so. And also, you're going to have a very good approach because you're going to have an approach from the top of the patient to the head. So it can be a little bit scary to approach from the top because it requires a deltoid disinsertion, but it does not have any harmful effect, as long as you do an adequate reduction, reinsertion of the deltoid.
And Michelle, the best results of a proximal humerus IM nail would be for two-part surgical neck fractures, right?
I would say that if you're starting with your learning curve, definitely, but on the long term, and as you're getting more and more familiar with this type of device, the results are going to be as good with 2 or 3 or 4-part fractures.
And Michelle, I was just going through Pascal Boileau and Natalie Martinez paper that they published this year. And one of the most important factors Dr. Boileau says is the tuberosity reduction. So if there's, and the results, some of the poor results that have been described in literature were due to a tuberosity mild reduction, isn't it?
Definitely. I think I have to be very clear with that. One of the most important factors to have a successful outcome with this type of fractures is to have a greater tuberosity reduction, anatomic reduction, and fixation, because I think that is going to make a huge difference in terms of decreasing the possibility of having a vascular necrosis and keeping just the patient function, because you're going to have a functional rotator cuff.
And Michelle, you told me that in the last 3 years, you've been using mostly IM nails, right? Only IM nails. And and isolated grade tuberosity fractures?
No, in those cases, I would use screws, cannulated screws. That will be my choice of implant.
Okay. And what about fracture dislocations and anatomical neck fractures?
Probably I will, well, it depends on the time of evolution. If I'm going to have a dislocation less than 3 weeks, then I will still do a nail treatment. But in cases of more than 3 weeks of evolution, probably the head is not going to be in the best shape. It's going to develop a vascular necrosis. And in those cases, probably I will aim for a replacement, anatomic or reverse, depending on the case.
Thank you, Michelle. Michelle, I think that's all the questions that we have for this session. Thank you for this enlightening lecture. And I'm sure this is
Thank you
going
very
to
much.
attract a lot of interest.
Hopefully. Thank you very much for the invitation. I'm very glad you invite me. Thank you very much.